And so with that, I'm going to turn it over to Dr. Betty Alessandro. Sanasidro. Oh, all right.
No worries. No worries. Thank you so much, Penny. Well, good evening, everyone. Thank you for being here today. And more importantly, thank you for caring about an issue that is too often overlooked but urgently demands our collective attention: workplace violence in healthcare. Every day across hospitals, clinics, long-term care homes, and in community settings, healthcare professionals show up to heal, to comfort, to serve. But far too often, they are doing so under the threat or the reality of being harassed, threatened, or physically assaulted. In fact, nationally, healthcare workers account for nearly 3/4 of all non-fatal workplace violence injuries. And right here in Massachusetts, a worker in a hospital is assaulted or threatened every 36 minutes. The people we trust to care for us at our most vulnerable are being harmed while doing that work. This isn't just a security issue, it's a public health issue, a workforce issue, a patient safety issue, and a moral issue. It affects burnout, turnover, mental health, and the ability of teams to function, all of which ripple to patient care. What's more, many of these incidents go unreported. Why? Because some staff have been told explicitly or implicitly that violence is just part of the job. Today we say, no, it isn't, and it shouldn't be. That's why we're here, to elevate this conversation, to learn from those on the front lines and in leadership, and to discuss practical, systemic, and policy level solutions. Over this session, we'll explore the scope and consequences of workplace violence, the risk factors that leave certain settings and staff more vulnerable, the intervention strategies that work, and the policies and advocacy efforts shaping the path forward. I'm honored to moderate this discussion, and even more honored by the panelists who have joined us today, each bringing unique insight, expertise, and a commitment to change. Let's begin, and let's do so with urgency, clarity, and compassion. Our first speaker this evening is Deborah McGregor, who is Director of Clinical Coordination for the Pre-Licensure Nursing Program at Regis and adjunct faculty member. She has earned 2 master's degrees, one in healthcare administration and the second in nursing leadership and informatics. She has also completed 2 certificates, one in integrative health and another in clinical simulation education. Her background includes clinical expertise developed through a diversity of clinical experiences over 15 years, including school nursing, camp nursing, pediatric nursing. Her role as a float nurse in the ICU, ER, step-down, and telemetry units. Her continuous role as a volunteer in the Medical Reserve Corps, and most recently, staff nurse and charge nurse in the emergency department at Metro West Medical Center in Framingham. She is an active member of numerous organizations, including but not limited to the Massachusetts Nurses Association, where she serves on the Workplace Violence Task Force, and the Massachusetts Nurses Council on Workforce Sustainability, where she serves on the Clinical Placements Committee. She's also the School of Nursing's representative to Nirvana, the Northeast Region Veterans Association Nursing Alliance, an alliance of colleges which provides continuing education programs for nursing. And in her spare time, she's pursuing her doctoral degree. Tonight, she will address the scope of workplace violence and its consequences. Being a nurse in the ER, she has seen a great deal. Our second speaker is J.D. Boucher, Workforce Safety Manager, Quality and Safety Operations at Parkland Hospital, where his primary focus is workplace violence prevention. He brings 40 years' experience in healthcare to his presentation tonight. He started as a combat medic in the U.S. Army and later became an Army nurse serving in 16 combat missions, where he was awarded a Bronze Star for heroism and a Purple Heart, among numerous other honors. He is active on multiple shared governance councils and interdisciplinary committees, including nursing research, quality, leadership, safe environment, and preserving the environment of care, to name a few. He is active in his community, sitting on 3 nonprofit boards of directors and volunteering hundreds of hours a year to nonprofit charities. JD currently sits on the National Board of Directors for Association of Perioperative Registered Nurses and serves as president of the Texas Collaboration of Perioperative Nurses and former 3-time president of the Dallas AORN chapter. As a member of the Texas Nursing Legislation Action Committee, he focuses on the passage of surgical smoke evacuation legislation for Texas healthcare systems. JD has recently completed his fourth master's degree and, like Deborah McGregor, is engaged in doctoral studies. Tonight, he will focus on the factors that put healthcare workers and settings at risk. Our third speaker is Karen Garvey, who serves as Vice President for Safety and Clinical Risk Management for Parkland Health in Dallas, Texas. Her responsibilities include health system oversight of regulatory and accreditation, patient safety and clinical risk management, and quality and safety education. She is an executive sponsor for Sparks, supporting Parkland staff peer support group, and chairperson for Enterprise Workforce Safety Initiatives. She's active on local, state, and national committees to collectively address violence and is often requested to speak in forums about interventions to address the issue. In March 2023, she testified in support of the proposed Texas Senate Bill 240 to protect healthcare workers against violence, which was unanimously supported and signed into law in May 2023. Tonight, she will speak on prevention and intervention strategies to address the issue of workplace violence. Our fourth speaker, Dr. Cami Daniello, is a seasoned nurse leader, association executive, and health policy advocate who currently serves as executive director at ANA Massachusetts and executive director of the Foundation for Nursing Advancement in Massachusetts. She is described as a motivated, goal-directed, process-oriented professional nurse with a broad range of successful management experiences in nonprofit, healthcare, and higher education organizations. She has a comprehensive understanding of regulatory and accreditation standards, in addition to leadership development, which she brought to ANA Mass in 2019. As executive director of ANA Mass, she has spearheaded advocacy efforts on behalf of all Massachusetts nurses, coordinating visits with legislators, organizing testimony, and conveying nursing perspectives in state policy debates. Her work has extended into shaping legislative priorities around several issues, including safe staffing, licensure reform, hospital governance, and most recently, the importance of an expanded definition of workplace violence in healthcare settings. She also served as an inaugural commissioner on the National Commission to Address Racism in Nursing. While most of her work is at the state level, tonight she will also share what the ANA is doing at the federal level. Following Cami will be Emily Rumble, a faculty member in the SON at Regis and DMPC, who will demonstrate how one person acting at the individual level can potentially affect hundreds of future nurses' experiences or lack thereof with workplace violence. These last two speakers make clear how nurses' voices on data can and must inform effective workplace violence prevention strategies. Deborah McGregor, I will now turn the program over to you.
Good evening. Thank you for this opportunity to speak on this important subject. I'm delighted to be here. I wish we didn't have to speak about this subject, but since we do, I'm glad to see so many people in the audience, and I'm going to do a quick overview of workplace violence and how it affects nursing, looking at the nursing shortage before the pandemic hit and what's continued since. We're going to look at some statistics and trends. We're going to look at how it affects all healthcare workers negatively, not just nurses, because we all work as a team, including mental health consequences of having repeated exposures to the violence, what burnout syndrome is, and the negative consequences to the healthcare settings in general. So workplace violence is defined as an act or threat of physical violence, harassment, intimidation, or other threatening. It can be for from recipients, students, family members. It can be from coworkers, colleagues. It can be verbal, physical, sexual, or psychological. The CDC categorizes it in 4 types that are described here. I'm not going to read the whole slide, but we have criminal intent. We have, which is type 1. We have type 2, which involves some like a customer or a client that becomes violent, which is really probably what we most see in the healthcare service area. We also have, that's type 2. And then type 3 is worker on worker that I would hope we would never see in the healthcare area, but unfortunately we do. And type 4, which is somebody that comes in that's looking to just be violent, and they have this intended target. And sometimes that, or oftentimes it affects others who were not the intended target, but become the victims. So as we all know, before the pandemic, there was a nursing shortage. In 2020, which obviously we didn't have numbers from a pandemic yet, WHO was already saying that we needed 9 million more nurses in the world, which is a lot. Other things that were trending then that we all knew were problems were nursing schools enrollments were not keeping up with projections of our needs. There were shortages of nursing faculty. There was shortages of clinical sites, which I can attest to still happen today. An aging nursing workforce, an aging population of our patients or clients, and poor staffing, which have led to nurses leaving the profession. So a nursing study in 2023, showed that there were things happening way before COVID happened. And the pandemic outcomes were just worse in hospitals that had prior poor staffing policies before the pandemic even happened. So during the pandemic, some of these things we already are aware of, and I just talked about, were just highlighted by the explosion of the pandemic and COVID. And things just continued to get worse. There was reutilization of staff because different areas closed, or people were laid off, or needs were different. So some people either were furloughed or lost their jobs or had to learn a new portion of the hospital. People in outpatient were learning inpatient, people in inpatient were learning critical care. All of these things are very stressful. Also in March of 2020, at least 35% of college-bound students that we would have hoped some would have gone into nursing decided to take a gap year, putting off when they would go into nursing or other health professions. There was significant job loss or furloughs, which affected parents' ability to pay for college. There was an explosion of applications to nursing school, but there were very limited slots. And what else happened then? We had to go virtual. So we had online and asynchronous learning, lickety split over a weekend, pretty much. If anybody out there is in academia, you know what I'm talking about, which put great challenges and limitations on all of us and all of the students. At first, there was no clinical placements of any kind. And then when we got back in there was limited. So not only did we have people putting off school, but people that were in school were getting less clinical placements and less on-hand experience than we would hope. And we had people that were graduating feeling inadequate, feeling like they got cheated, and going out into the workforce. And also, something that delayed everything was people had trouble taking NCLEX exams because the exam facilities were closed. So there was a lot of things that continued with our frustrations of staffing, and then more issues that just compounded the problem during the pandemic. So afterwards, everything still existed. There were still the same problems as before. And in 2021, in that 1 year, the RN workforce decreased by 100,000 people, greatly related to the pandemic, but that's really a shocking number. Along with the staffing pre-pandemic that was still the same, we see that there is measurable associations between nurse staffing and safety. And inadequate nurse staffing also is related to poor patient care and poor outcomes. And 80% of nurses who experience workplace violence in a single year, which was in 2024, was reported by the BNU, cited short staffings, unsafe staffing as a major factor. As you can see on this slide, I said staffing, staffing, staffing in bold because there's a pattern here. Okay, so moving from staffing and how it was affected before, during, and after COVID, we've seen also an incredible increase in workplace violence. And these are just a few of the statistics and trends that I found out there. The first one that is I find really shocking is the 175% increase in hospitals. And that was actually recorded in 2020. So that was even before the pandemic, when people became more anxious, more concerned, worried about their loved ones, worried about care, not being able to see loved ones that were sick. So we're seeing that workplace violence has been a problem for a while, and it's just getting more and more prevalent. In 2022, Press Ganey reported that 2 nurses per hour were assaulted. And OSHA announced in 2023 that healthcare workers are 6 times more likely to be injured than other industries. On top of all of this, we're hearing that many nurses want to leave their current position and/or leave the profession altogether, which certainly is not helping our nursing shortage. The other aspect of workplace violence is it's underreported. So all of these numbers that I'm sharing with you are not true examples of people being affected by workplace violence, whether it's verbal or psychological or physical. It's vastly underreported. As the moderator stated, a lot of people feel that it's just part of their job and it's just something we have to live with. A lot of employers don't have policies, procedures, proper education, again, proper staffing. There's a perceived intent from the patient that, it's okay. Some people don't report because the reporting system's complicated, or, they didn't get hurt, so they feel like it's not important. Some places, people have said they don't have supervisor support, or their fear of retaliation. But the fact that it's underreported and people feel that it's not, that it's just part of the job, and that we just need to live with it, and it takes too much time to fill out. It just goes to show that there's really so many more people out there that we haven't heard from. So, like I said a few minutes ago, we're not only talking about nurses here, we're talking about all healthcare workers. And OSHA lists inadequate staffing, again, staffing, as an organizational risk factor for workplace violence. It's also linked to the nursing motivation for career satisfaction. And it's also listed as an impacts quality of care and patient safety. Workplace violence leads to job dissatisfaction and toxic work environments if it happens to be worker to worker or bullying. And it's again leading to more and more people leaving their positions or leaving the profession altogether. Burnout, depression, and dissatisfaction with the work environment and the staffing is a leading cause of losing nurses from our profession and other healthcare workers. And again, it's linked to burnout and patient safety. So staffing and patient safety is linked to burnout and linked to workplace violence. A study by Hawaii looking at nurses' mental health was looking at both direct, indirect, or being exposed to both types of workplace violence. And what they mean by direct is, actually you being the victim, or indirect as you see someone else being the victim and you're exposed to that. And nearly 85% of the sample reported that they had had some kind of workplace violence within the last year. And this study was in 2021. And it did not really matter whether it was direct or indirect. There were 1 out of 2 nurses met the criteria for experiencing PTSD after either indirect or direct or both. And nearly 1 out of 3 met the criteria for anxiety, depression, and burnout. So the mental health consequences of workplace violence is there's been a rise from 2021 to 2022 from 6% to 13%. And harassment also leads to anxiety, depression, and burnout. So harassment can mean verbal from a patient, it can mean verbal from coworkers. Workplace violence also negatively affects both personal lives and our professional lives. And repeated exposure leads to sleep disorders, fatigue, PTSD, and healthcare worker burnout. Burnout syndrome, which is a occupational phenomenon defined by WHO, has three characteristics: a feeling of energy depletion and exhaustion, increased mental distance from one's job, or feelings of negativism and cynicism related to one's job, and reduced professional efficacy. This is not a medical condition, but what they refer to as an occupational phenomenon. So I am speaking to you tonight not only as a concerned nurse and professor, but also as a victim. And I wanted to quickly share my story. One of the reasons I'm on the MNA Workplace Violence Task Force with the moderator is because of my story. I was a victim of verbal and physical assault by an intoxicated patient. It resulted in 2 wrist injuries requiring surgeries. I was out of work for months on disability, in months of rehab, months of light duty. I ultimately lost my healthcare coverage and my financial stability. I suffer from chronic pain, and it took me a very, very long time to admit, but I was suffering from PTSD. And I finally admitted it one day when I was actually on a integrative health retreat, and I was with a bunch of emergency room nurses, and we were all kind of feeling that we could do some sharing. And I finally realized that I was suffering from PTSD and I couldn't go back to the emergency room for a while. And it was very painful for me to resign from my position after almost 30 years and lose my seniority. And I missed my friends terribly, but I could not go back for a while. But I would like to tell you that I did go back about a little less than 4 years later to the back to the same emergency room, and I'm thrilled to be back at the bedside. But I'm also thrilled to be part of this movement of nurses and other healthcare workers and educators who are going to say no to workplace violence from now on. For the healthcare settings themselves, there are several negative consequences, some of which are productivity, employee satisfaction and retention. It costs the US $151 billion per year, which I was a little surprised, but I guess I shouldn't be. And the average cost per incident is $250,000 per incident. And of course, like myself, there's hidden costs. There's emotional pain, depression, anxiety, PTSD, all the things we've mentioned. And nurses exposed to type 2 or type 3 violence tend to have consequences of more patient falls after, delay of care, clinical and medication errors, which is unfortunate because it's not their fault they were exposed to the violence in the first place. Looking to the future and looking to my colleagues who are going to speak after me, some of the things that I'm hoping to see is more education about workplace violence in the academic setting so our students can go out into their new profession prepared, and that employers provide prevention education programs, provide friendly policies for reporting and tracking, and also provide support for their employees who are victims. And I know that some of the other speakers are going to talk about the current bills in Massachusetts to help with implementing prevention programs and education in our from our employers. And also, we're going to hear a lot more about the federal bill that is going to hopefully result in tougher criminal penalties. And with that, I'd like to thank you for listening to me and send it back to the moderator.
Deborah, you can turn it right over to the second speaker, which is JD Boucher.
And thank you very much for sharing that with us, Deborah. I am going to go ahead and go forward with this, and we're going to speak to you about the factors that really kind of put healthcare workers and settings at risk. And I'm going to do it in a way that we could do a comparison on this between the airline industry and healthcare. So I think a lot of us already have a fuller understanding of the uh, really how the workplace violence in airlines has really come about because it was so televised nationally. So, but before we get into this, I want to tell you a little bit about our facility. Karen and I work at Parkland Health here in Dallas, Texas. It was founded about 176 years ago, and right now it's currently licensed as at 882 beds, but we are actually growing. We are a safety net community-based hospital here in Dallas, Texas, and we are urban hospital also. We have the busiest emergency department in the nation for a standalone hospital. We saw roughly about 250,000 patients last year. We have a very large behavioral health and homeless population that we serve. And we are also the primary teaching hospital for UT Southwestern, right down the street from our facility. We also are healthcare providers for our Dallas County Jail. Currently, we have about 7,000 inmates at the Dallas County Jail. And we are the first burn center in the North Texas to be verified by American Burn Association. We are also a level one trauma, first level one trauma in North Texas, and level four maternity center, birthing about 34,000 babies a year, and level three NICU. So with that, I really want to go ahead and start really focusing on some of these, what we're facing with this silent epidemic. One thing that I would say is that the societal stressors of the mental health decline was really seen right after COVID. So we had that post-pandemic trauma of COVID that left lasting psychological scars, grief, isolation, and even fear with heightened emotional volatility. We also went forward with the mental health crisis, rising rates of anxiety, depression, substance use disorders among the general population really increased the likelihood of aggressive behavior in the healthcare setting. Again, as it was mentioned by Deborah, we also have burnout amongst our healthcare workers, but we also had those economical pressures that came along with the economy that was stressing. We had the financial insecurities, so we had our patients and our families that were facing economic hardships that may be more reactive and or confrontational when navigating healthcare costs and those access issues. But what about the underfunded healthcare systems? How are these budgeted constraints leading to understaffing, which Deborah had mentioned, but also that increases the longer wait periods that our patients are dealing with. And it's also reducing that security measures that we may be putting into place. Maybe conditions that escalate tensions and risk with our patient population or even our staff members. Other things that we can think of is healthcare worker shortages, which Deborah mentioned, but the political climate and maybe the misinformation that is coming about, the polarization and the mistrust that is carried with that. those political divisions and misinformation, especially around public health measures, have eroded the trust in healthcare professionals. We are seeing that providers are increasingly targeted for perceived affiliations or decisions, especially in contentious areas like reproductive health, vaccines, and even end-of-life care, or those legislative gaps that come in with the inconsistent laws and enforcement around healthcare worker protections that leave many healthcare workers very vulnerable. Organizational and environmental factors can show us that we have inadequate safety infrastructures, poor facility design, lack of emergency communication tools, or even unrestricted public access, which is increasing our risk. What about the normalization of violence? Many of our healthcare workers see violence as a part of their job, which discourages reporting and interventions. And then also we have that lack of training and prevention programs where many institutions still lack those comprehensive violence prevention strategies or fail to invest in that staff education. And lastly, there is that cultural and demographic shifts, changing patient expectations. Patients now expect faster, more personalized care, and often have that unmet expectations that can trigger frustration. Diverse workforce challenges are also a part of this. Language barriers, cultural misunderstandings, and discrimination can contribute to this conflict. So when we get to thinking about our unfriendly skies, where we have our aviation that was highly reported in the media, so we have that what we call air rage. The increase of workplace violence in healthcare far outpaces that of the airline industry, both in frequency and in severity. The incident rates and risk exposure in the healthcare industry are seeing 5 times more likely to experience workplace violence in the healthcare setting than workers of any other industry. In 2021, 2022, the healthcare and social assistance sector had an annualized incident rate of 14.2 cases per 10,000 full-time workers. Basically, what that means is that we are seeing nearly 73% of all workplace violence cases in the private industry sector was in healthcare. We also saw 93% of all healthcare workers that were assaulted was actually against healthcare workers. In the airline industry, we are seeing those flight attendants and other gate agents and so forth. They have protection under the federal law, which criminalized assault and intimidation against them. While there was still that spike in unruly passenger behavior during the pandemic, federal enforcers helped curb those incidents quickly. And the lack of similar federal protections for healthcare workers has left them very vulnerable and less protected legally. With that legal protection, we also got to consider about the providers who are increasingly targeted. I am so sorry. We also have to focus on the benefits from vigorous federal enforcements that the airline industry and the workers saw under the laws. But healthcare workers, despite facing more frequent and severe violence, do not have the equivalent federal protections. So when I'm speaking of these addressing, what are the contributing factors to this violence? Well, in healthcare, we're seeing that it's an emotional distress, those mental illnesses, the substance use, those long wait times, and those staff shortages. What about the lack of security in the infrastructure, underreporting due to normalization of violence, and a high patient expectation and misinformation about care? Airline industries saw the passengers' frustration over delays, and remember those mandatory masks that they were made to wear during their flights, and even the travel restrictions that came along with that. Also, the airline industry does have that opportunity for alcohol consumption, which can increase the potential for violence. And the federal penalties and public awareness campaigns really help to reduce those incidents. But the impact on workforce and operations in healthcare, it led to increased burnout and turnover, as Deborah mentioned, but also we had a reduced patient safety and care quality that came from that, and billions in financial costs in healthcare annually. Airline violence saw that disrupted flights and the safety, but also it was episodic. Strong legal deterrence really helped maintain that. So basically, in summary of this one slide, it was like while both healthcare and airline workers face workplace violence, healthcare professionals experience it more frequently, more severely, and with fewer legal protections. The disparity of the enforcement and prevention underscores the urgent need for federal legislation to protect the healthcare workers with the same rigor as that we had saw with the airline industry. So what about what's happening in our healthcare headlines that we're seeing? The lack of national reporting on the media covers on workplace violence in healthcare is a multifaceted issue. As I stated earlier, there's that normalization of violence in workplace. Many healthcare workers, especially nurses, have internalized the belief that workplace violence is just part of their job, leading to the silence and the resignation. This cultural acceptance discourages reporting and minimizes the perceived severity of the incident. There's also that complex and burdensome reporting system. Reporting procedures are often time consuming, confusing, or even inaccessible to some individuals, especially during a busy shift. Staff may not know how or where to report or how they feel the process is when they are trying to achieve it. The lack of organizational support, many workers report that management does not respond adequately to incidents, which erodes the trust in that healthcare system. Also, some institutions discourage reporting to avoid legal liability and reputational damage. That fear of retaliation and blame may lead healthcare workers to be accused of poor performance or even face retaliation from a supervisor or a peer. The lack of standardization definitions and tracking. There is no national standard for defining or categorizing workplace violence in healthcare, making data collection very inconsistent. Verbal abuse, intimidation, bullying are often excluded from official statistics. And then the media underrepresentation. Violent incidents in healthcare rarely make headlines unless they are extreme, maybe a shooting. The media tends to focus more on violent in public spaces or industries like the aviation or law enforcement, overlooking the daily chronic violence healthcare workers are seeing. Underreporting skews the reality. Studies have shown that up to 80% of workplace violence incidents go unreported. This lack of data leads to underfunded prevention programs and weak policy responses and false sense of safety. And then there's also that legislative gap. Unlike airline workers, healthcare professionals lack strong federal protections against violence. Advocacy efforts like the SAVE Act, which will be discussed later on, will aim to address this, but progress on this is very slow. So in summary, the workplace violence in healthcare is a silent epidemic. It is underreported by staff, unrecognized by institutions, underrepresented in the media. Until we break the culture of silence and implement systemic change, healthcare workers will continue to face preventable harm without adequate protection. So there's been quite a few workplace violence publications that are coming out, and they really start to really focus on that patient-related risk factors that are associated. A lot of that could be mental health conditions, patients with the psychiatric disorder, dementia, or substance use. Issues may exhibit unpredictable or aggressive behaviors. But there's also that factor that we deal with a lot in our urban-based community hospital, which is that pain. If we have potentially our homeless population that may have drug and alcohol dependence, their pain scores may not be the same as what we would have, meaning that the medication that it would take to get those reduction in those pain would be more. And so we have to really establish baselines when it comes to that pain, but also there's that fear and confusion or even that history of trauma that could be triggered. And then what about the environmental and the organizational factors that may come into play with this? High stress environments, especially in the emergency department, behavioral health units, and that perioperative setting, are often have a heightened emotional intensities. As we had mentioned before, that understaffing leads to longer wait times, reduced vigilance, and increased frustration among patients and families. And the poor facility design, limited escape routes, unsecure areas, or inadequate lighting can increase the vulnerabilities. There's also that lack of security presence. Insufficient or poorly trained security staff can delay responses to the incident. Nationally, there's a systemic of the policy gaps too. Inadequate training, staff may lack de-escalation training or awareness of reporting protocols. So, but the statistics are very alarming when it comes to this. I'm sorry, I'm going to go back to this. So there was some statistics that were given earlier, but as we do a new employee orientation every week, these are some of the statistics that we have done, and it's something that we update almost monthly, it feels like nowadays. But 81.6% of all healthcare workers experienced workplace violence in 2023. 3 nurses now, by the press Guinea, are assaulted every hour in the United States. If we really start to think about that, because it's easier data for us to get that 3 nurses are assaulted every hour, what about the rest of those healthcare workers? What about our providers, our phlebotomists, our nurse assistants, our nutritional support? When we start to pull all together, everybody that's working and supporting that healthcare organization, it's amazing how much of an increase you're seeing in those numbers. 71.9% experience verbal aggression routinely. Personally, I feel that that number is a little low. When I first came into this role as a workforce safety manager, we had under 100 verbal aggressive reports in the first year. Now we are seeing hundreds and hundreds and hundreds of them. And what that does is it gives us the data needed to be able to promote and really effectively change those. Right now, each hospital, every single hospital in the United States spends about $330,000 per year on workplace violence, and $56 billion is annually spent on healthcare alone every year for workplace violence prevention. And the last thing is that healthcare workers are 5 times more likely to be assaulted than any other industry in the United States. In Texas, Karen and I, were very diligent in testifying and really focusing on implementing this tool before it even became law in our healthcare facility. Senate Bill 240, which was actually sponsored by Senator Donna Campbell, who was an emergency room doctor, required that hospitals and other healthcare facilities to implement a workplace violence prevention plan. They must also maintain a workplace violence committee and provide that workplace violence training at least annually, prohibiting retaliation or discrimination when events are reported. This law became effective in September of 2023 and was amended in September of 2025 to include the ambulatory surgical centers and home health agencies that have more than 2 RNs on staff. Senate Bill 840 was a big accomplishment for the state of Texas, but also it really gave us the marching orders to start to make sure that we get this across the nation. I am currently in Oklahoma right now, getting ready to testify tomorrow. Senate Bill 840 by Senator Royce West out of Houston, Texas, enhanced the penalty for assaulting a hospital worker to a 3rd-degree felony from a misdemeanor. Before, if you were to hit a healthcare worker, it would be like getting a jaywalking ticket of a $50 fine. Now you can go up to 10 years in prison. And that's a big factor that has really given a lot of confidence to our healthcare workers. So when I go on to speak on this chapter 331 is what our Senate Bill 240 turned into, it really started to do 3 key requirements. And the first one is that workplace violence committee, but it must include 1 registered nurse that is in direct care, 1 physician, and 1 security staff member if that is practical for your healthcare organization. The other things that it required is that you have a written policy and a prevention plan. It must be developed, implemented, and enforced. And that must include reporting mechanisms, anti-retaliation protections, and evaluations of existing plans. And thirdly, the incident response protocols must be put in place. Facilities must respond to and document the incidents. Also, they are encouraged confidentially to have confidential reporting by that staff. So I'm just going to touch on this a little bit because I've actually been to Washington, D.C. Several times to testify on this and to also advocate on behalf of the SAVE Act. This bipartisan bill, which right now has 183 bipartisan support, is modeled after the federal protections for the airline workers. It would establish federal criminal penalties for knowingly assaulting or intimidating hospital employees, with the exceptions of individuals who may be mentally incapacitated due to illness or substance use. It authorized grant funding for initiatives to improve hospital employee safety, and the SAVE Act for Healthcare Worker Act is one step towards ensuring that healthcare is no place for violence and giving hard-working professionals the protections they deserve. I'm going to turn this over to Karen. Karen?
Thank you, JD. I'm going to be addressing some of the prevention and intervention strategies, many of which we have implemented in our own organization. Being the chair of our Promoting a Safe Environment Committee, which is actually our workplace violence committee. I've been working on this since I came to Parkland 11 years ago, and even in prior organizations before joining Parkland. But when we actually look at our mission, vision, and value of the organization, advancing wellness, relieving suffering, developing and educating is our mission, vision, and values. And we've also brought into our value or our values of I care, where we're looking at integrity, compassion, collaboration, accountability, respect, and equity. Back in 2021, we started on a high reliability journey and realizing that many organizations across the U.S. had embarked on a high reliability journey prior to COVID, but also realized that many of their practices that they had in place were pretty much obliterated during COVID. And so many of them had to restart those processes. But as we looked at, and when you look at high reliability, there's really a focus on zero harm to patients. But we incorporated the concept that you can't have zero harm to patients if you don't have zero harm to your healthcare workers. So we really combined both of those together, realizing that there had been so much emphasis on patient satisfaction, the way that healthcare organizations were with star ratings when it came back to their HCAP scores and everything. There was a lot of emphasis on the patient component, but little emphasis on the workforce. And so the way I analogize it is, in what I have spoken out, is that we can't just have the patients in the front seat of the car and the healthcare workers in the back seat of the car. They both have to be together in the front seat with the same level of resources for those healthcare workers to provide their best level of care to patients at the bedside. So we've incorporated this into our mantra regarding high reliability. And next slide, please. Goes into our strategic priorities. So back in 2017, we when you do engagement surveys, when we do enterprise risk management surveys, we identified workplace violence as one of the top 10 risks within our organization. So fast forward a couple of years into 2019, the violence became higher on in the top 10. And certainly during COVID, it became even higher. So we developed under staff and provider engagement an actual strategic priority that focuses specifically on mitigating violence for healthcare workers. That has since expanded into looking at more of the wellness component since that time frame. And it's a strategic priority that the EVPs have to actually report out to the board. And it has also allowed me to get staff into place where, when I came here back in 2018 and was working on this for several years, I was able to actually create a position that JD now occupies, but in addition, another position for somebody who actually works underneath him. And these folks are 100% devoted to managing the workplace violence events that come through our event reporting system. So we do have to provide updates. The organization has helped us to provide resources for this, and we've been a strong voice and an advocate, but also working collectively with some of our colleagues across the organization, as you'll see in the next slide. This is our actual structure. It is one that works for us. It's not perfect, but it has expanded over time. But it shows how high and the visibility is to our work, our board of managers, our quality board of managers as well. And then we also commissioned an executive oversight committee a few years back because as a leader in the organization, but not sitting in the C-suite, I needed our C-suite folks to really understand what our employees were actually managing or having to interface with day to day. Reading some of the letters, some of the event reports that come through, the incident reports, I was horrified by some of the verbiage that they're having to endure, just some of the injuries that they were having. And so I wanted our leaders to know. And so that executive oversight committee is actually comprised of the COO, the CNE, a head of HR, somebody in legal, our chief medical information officer, chief quality and safety officer, myself as the chair, JD, and a couple of other folks. But it helps to provide them information as to some of the needs in the organization. We have a quality of care and patient safety committee, and JD and I report out twice a year at least to that committee to provide them updates. And in addition, we also bring cases. So just as you would in a healthcare organization do root causes or case reviews on patient safety events, we do the same for employees that are involved in serious workplace violence events as well. We bring that information transparently all the way up the line so that the board of managers sees and hears what's going on in the organization and what's going on with our workforce when they are injured. We also have a Preserving the Environment, a care committee, which I'll go into a little bit more, but this actually showcases or actually helps us to review those repeat offenders that are coming in, where even through warning letters or modification of services, where we try to do what is right and least intrusive in the beginning, but they're just not correcting the behavior. This gives us the ability to actually review cases both from an objective point of view, from looking at incident reports and documentation in the record, injury reports, but also looking at their trauma history and actually discharging patients from, again, we're a safety net from our entire system, and we have done that. And then the Promoting a Safe Environment, again, is our term for our Workplace Violence Committee. But as you can see, we work with many folks in the organization. I call it a full court press because we are locked arm in arm moving forward when it comes to facilities, legal, the operational folks, our clinical informatics, as you'll see later on here, actually helps us to provide some of those alerts in the system. And then, just so many other folks, our Office of Talent Management is actually our HR folks, and they've helped us to actually reposition people in different roles in the organization when staff have felt threatened and cannot leave the organization because they can't have a job, they won't have a job, but to actually reposition them in another role in the organization where they feel safer. We work with our nursing folks for Magnet. We had a great presentation for our Magnet survey in August. We were really proud to present there. Hopefully we'll get that designation. We're working with our physician groups and utilizing trauma-informed care, but definitely you can see every box down below. They all have different levels of risk. The ED and behavioral health, absolutely. So they have a committee that's chartered. They have their own goals. JD mentioned our 7,000 inmate jail that we actually manage the care for. Very different when it comes to what they have to interface with inmates, as well as on the unfortunate sheriff's office with some of that lateral violence that comes from them. And we have advanced practice professionals that are sprinkled among many service lines that were not getting enough information. So we created a committee specifically for them, and they've done tremendous work. Ambulatory surgery centers, many of these folks have, these buildings have pain clinics in them. And when you've looked at some of the shootings that are across the country that have been, where people have been harmed and killed, it's in these very buildings. And then when you also look at the community setting, those folks that are doing awesome work going into homes, but don't have any brick and mortar protections around them. I will say that our law, when it first came out, had included this setting. And since then, when it went into the final signage, it was written out. But I know that OSHA has provided some guidance earlier this year on some of the new rules that they put forth for those folks who are out in the community setting. And then we've just recently put together a frontline workforce violence committee, which is comprised of frontline across the system. And we have had a huge, huge interest in folks that want to be champions in this space, because we realize the work that we're doing at the higher levels in the organization does not always translate down to the front line. So we're trying to work to bridge that gap with the frontline workforce. And again, this is a structure that works for us. Next slide, please. And so going into event reporting, I've implemented 4 different systems in my risk management patient safety career. I am a nurse and I've just taken a different path, but I will tell you that we've worked diligently to create an actual icon for our system. And typically these icons are in alphabetical order. And certainly if you look at workplace violence, it would normally be almost off the screen. We were very intentional about putting it first. And it comes right near the behavior category. And so when we actually look at the definitions, and I know Deborah had talked about what types are out there, we break ours down to a little bit, being a little bit more granular. We break them down into physical violence, or physical assault, verbal assault, disruptive behavior, destruction of property, and sexual assault. And many times it's one, some, or all of those items. Typically, verbal assaults precede physical assault. So many times you may have 2 events. And prior to our transition to this system 2 years ago now, we were only able to capture 1, when many times you should be able to capture all 5 of those items. So now we are able to do that. So when you look at the data on our next slide, you'll see that, let's see, can you move it forward, JD? It's stuck. There we go. We have roughly 1,900 events reported for fiscal year 2020, which we just ended September 30th for 2025. It supersedes the year before, which is roughly 1,700 events, but we've been doing diligent work. JD and Marissa, who work in this space, have done a lot of extensive training. They show up in new employee orientation. They're the messengers as to why this is important, that this is not part of our job. But when you look at the primary, which are the purples, that's the initial event that comes through the system. But when then we're capturing that second, third, fourth, and fifth event, that is actually in the gold or the secondary bars. But you have to realize that those numbers on the bars are actually compressed, where they're only really capturing 1. So one of our goals for 2026 is to actually break those out a little bit more, so we can capture them all. In addition, next slide, please, moves into putting a rate together. So when you look at the actual rate, when you look at the DART rates that are out there, it is a standard calculation of the number of workplace violence incidences times 200,000 divided by total work hours. Again, this is not a perfect calculation, but when you look like at the month of March in this slide, or the month of August in 2024, for March of 2025, over 18 individuals out of 100 were assaulted. That's almost 20% of your staff per 100 workforce members. So again, this is still a compressed number, but it's something that we didn't have prior in 2023. In addition, when you actually look at the number of work hours, we get this from our HR area, it is everybody. So realizing these last few years, we've had a lot of remote workers, it does include them. So now that we're transitioning into more of a on-site hybrid or totally remote workforce, as of January 1, we'll be able to capture and break this down a lot further, where we can be a little bit more accurate. Next slide, please. So moving into a tiered process of how we manage this, We've learned over time that, and we've worked with our legal department using trauma-informed language, that we can actually start to investigate these events as they come through to JD and or Marissa. An event is reported. They're pretty explicit in the brief factual description where they describe the behavior. They're also describing it in the medical record. And so they initiate a formal procedure, and they put out a behavioral expectation letter. That letter outlines what we expect of them, how we expect our employees to actually behave as well. But it also lists the information, describes exactly how they behave based on the medical record documentation or the incident report documentation. So we feed it back to them and let them know. We've been pretty successful with utilizing these initial letters to let people know that this is what we expect of you when we come into the organization, regardless of where you actually show up. In addition, we also provide them our rights and responsibilities components along with that letter. If they continue the behavior even after the warning, it escalates up. They do a disruptive behavior advisory. We put alerts on their record, which we'll show you later. And then we can also escalate it up to actually moving to a termination process where we review both, again, objectively from the medical record for the last 12 months and look at information of how they may be behaving in other healthcare organizations if they've been in the ED, but also look at their trauma history, because sometimes we may be triggering them when we don't even know that we're doing that. And so this information, as the committee deliberates, and again, it's a nimble committee. We put it together. It's psychiatry, it is psychology, it is nursing, it's care management, it's legal, it's ethics, it's JD and myself. But there's people that are actually committed to looking at these cases and making a determination. But we also allow testimony from the area who is requesting to terminate the patient and wanted to find out what we have done up to this point in time. And then this information, based on the deliberation and outcome of the committee's discussion, goes to our chief medical officer, who will say, yes, I support it, or we'll push back and say, nope, we need to do better for this patient, or we'll ask for some additional information. And so we've been very successful. We've been doing this for about 2 or 3 years now. And the next slide will show you how well we've actually done with just letters. So year 1, 109 letters were written. We had a 95% success rate, meaning that following year, of which we're required to actually review these cases a year after the following year, we had a 95% positive response rate, meaning they did not have another reported event. Year 2, almost double the number of letters, an 88% positive response rate. So we're seeing that the least intrusive measure of having a behavioral expectation letter sent to individuals can have a very positive impact on patients. And even to have a patient call me wanting to know why he received a certain letter, after explaining it to him as to how he needs to behave, he truly was apologetic and could understand it. And because he had also worked in a local healthcare organization and understood it as a healthcare worker. So again, I think it's a pretty good success rate, and it's something that we're continuing to monitor. Next slide, please. Goes into what we've also done from the other levels that I've shown you. We've had some disruptive behavior reviews, 17 from inception, and we've also had, when we look at the modification of services, which may include discharge from the system, we've had 33 of those, and I believe 23 of them, JD, correct me if I'm wrong, have been terminated from the system. So we give them a 30-day time frame. They can come into the emergency department. Their final letter tells them that they can come back into the emergency department to seek care in that space, but clinic appointments are canceled after that 30-day time frame. Providers and individuals who have touched that patient over the previous 12 months are notified of that termination, and there is a termination screen that you will see later on that does come up as well as a warning. When they do come in, and they have come in, we've developed a fast track process called a safety scrum, where it is a nimble committee or a nimble group of healthcare workers that actually work with the patient to get them stabilized for discharge, or if they have to be admitted, then they have concentrated care to get them to a stabilized state to get them discharged to a safer place. So again, this has been our process, and it's been very, very successful managing the patient from the care perspective, where in many organizations, they're managing it more from the forensic and more from the police and security perspective. So this is why as a full court press, we continue to work together, and I think have good outcomes. Next slide, please. So part of our workplace violence law, Senate Bill 240, which has now been codified, as JD had mentioned, requires a workplace violence plan. So as the law became effective, as of September 1 of 2024, all or healthcare organizations, in addition to what JD had mentioned regarding the required folks and individuals, the reporting process, et cetera, also required you to have a plan. Now, I started to work on this back in 2018 when the law first came out. I had not realized that it had moved off the docket during COVID, but we continued to work. We are now on our 6th workplace violence plan, realizing it was just last year that we had to be compliant with it. So we put together goals. We put together a plan. We proposed the plan and the goals to our executive leadership. They approve them. And so our plans, our goals for 2025, next slide, all 5, we put 5 of them on there. And they were all met and 100% complete this year. We have implemented Brissette. We've put panic alarms in places and done risk assessments in places where we had vulnerability, one being in the pediatric burn, for the pediatric population in the burn unit, which we are an adult-based hospital, but we have a large burn unit. We do see the pediatric cases. And certainly assessing not just the clinicians, but those, registrars, people who actually interface with patients before they get into the clinical area are also highly vulnerable. So we've done several risk assessments in those areas to assess for panic alarms, unnecessary protections, and certainly even as we have areas under construction, we're working with architects on how we actually place furniture in exam rooms, et cetera, where there's panic buttons before the entire construction project is done, because we don't want providers or clinicians, staff pinned in a room where they don't have access to exit. We've implemented the Brissette violence checklist as a phase 3. We did it in our inpatient psychiatric unit, our med secure unit, which is an elopement unit, and then we've done it in some of the medical surgical units, and that has been successful. And then we've realized we implemented back in 2020, I believe it was, a paid time off work policy. So if a workforce member is actually injured by workplace violence, an event, and they are off work, we actually created a time and attendance credential where we can track their time off related to violence. And that's been incorporated into the paid time off policy. And then last year on a pulse survey that we did in between years of our full engagement surveys, we put 3 questions on our survey that related to violence and safety and security, and how often they witnessed or were part of these situations. And so our goal, our final scores last year were like 3.96. And so we wanted to ensure that, which on a Likert scale of 1 to 5 was actually pretty good, year 1. And so we wanted to maintain or improve those scores. So we actually implemented them on our full survey this year. And we're very successful in surpassing the 3.96 for our 2025. So the staff are telling us that we're doing the right things and making sure that we're working hard to make sure that they're safe. Next slide, please. Goes
All
into
right.
the
Karen, excuse me, this is Penny. You've really got about 7 more minutes. And I know this is so good, but that's what you got.
Okay, thank you.
All right, okay.
So these were the questions that we asked. Next slide, please. And then these were the questions that the results that we had from this year's survey. So again, we surpassed what we did last year, and we're proud of that. And so moving into next slide, Supporting the staff. So we've had a peer support program that we call Sparks, which is about supporting Parkland staff. We implemented it in 2019. We utilized the Johns Hopkins RISE program. They came in and they trained us. And so we then launched our own basic training the year after. But 2019 is when we started. We had a year under our belt before COVID, and we desperately needed it during COVID, because certainly things have changed. But next slide, please, goes into why it's needed. This will show you definitely why, but certainly because of violence, but all these other items that are on there. But really, the peer supporters are a tier one. It's really that just getting them back to implementing the psychological first aid, but actually escalating up the chain as needed. And so we continue to work with our peers across the health system. And looking at, next slide, please, the amount of contacts that we have had over time. So in the almost 7 years that we have been in existence, we have touched over 7,000 of our own workforce members. We are probably busier than our employee assistance program, but again, we work cohesively with them. So it goes to show you that we've continued to work with them. The next slide shows you the trends that what we are seeing for. This is a confidential. We don't write anything down. Peer supporters, we have about 60 across the health system that may be housed in the jail. They may be in the ambulatory care settings. They may be in IT, business office settings. They're from across the system, and they are true peers. But when you actually look at the types of why they're calling for support, the last couple of years, it's been just because of general stress and workplace violence. So there's certainly a ripple effect. I think, as Deborah had said before, it's not just the one individual, but it does impact several of the teammates as well as their family members at home. So we continue to be a strong, safe place for our peers to be able to go to. The next slide shows you some of the other elements that we have put in place. We do put workplace violence care packages, which are up on the upper right-hand side together, which provides something for every one of the senses: touch, feel, taste, smell. But these are some of the other things that we have in place. We have lavender carts that roll out that have items that are in our actual meditation room that we have built as a result of some of the funding that we've received from our foundation. So a lot of work that we continue to do and work again with our colleagues across the system. The next slide also shows some other interventions. We're making sure that people are here for a justified business reason by having a basic ID. You can just click through these, JD. We have definitely some security, weapons detection systems. We've done internal risk assessments. We encourage everybody to take a de-escalation training, not just those in the psych area and emergency room, but also we're transparent in our huddle every day. We actually read out the number of workplace violence events that have happened in the previous 24 hours. And that has given the executives knowledge that these things are happening in the organization and hearing it every day. And really, when we do our days since, it's been 0 every day but 1 since we started this. And then, as I mentioned, we also do cause analyses on employee injury cases. And then we also have done signage for various areas in the organization too, as to, what we expect of people when they come in here, but also that middle sign is what we expect of ourselves to kind of get ourselves in place, and composed before we actually go out and interface with others, because our words, our behavior, and our body language do also impact what goes on. And so we also have signage, some of the banners. You can flip through these, JD, pretty quickly. This is a stamp score that actually shows up if a patient is known to be violent in the ED. 100% of our folks are actually screened in the ED. And as JD had mentioned, many of our employees do not have access to the medical records, so we've developed this sign that goes outside the door to give them a clue that people may be violent and to find a partner to go in or to talk to the nurse. The next couple of slides show what kind of slides alerts actually come up in the medical record. You can go forward. The behavioral alert, as I mentioned earlier, will come up as a green, and it's in an SBAR format as to what they need to do when the appointment comes in. And in the ambulatory space during COVID, people that were known to be COVID positive had a purple hue across the actual screening or the actual calendar, the schedule. We've actually they had helped us to identify when patients may be violent by color coding their color on the schedule as well. And then the last couple of slides go over this is how the termination or the behavior alert comes in, which have the flags up in the left-hand corner. And then the next slide goes over the termination screen. So when the patient does come into the emergency room setting, this flag comes up to let people know who they need to call and then who gets deployed there. And then the very last slide goes into some of the items that we have put together. Again, the advanced practice provider workplace violence toolkit. JD and I were actually able to put together a article for AONL, and then I also was able to participate on a workplace violence symposium last December from a national perspective with AONL. And that's all I have.
Thank you very much. That was amazing. It really is. So I think we'll turn it over to our last, or actually, we need to do the 5-minute break. I promised everybody 5 minutes, and we really will start right back. And that would be at 7:47. All right. So everybody can go take your little break, get a coffee, do something, and we'll start right back up. So I think we'll go ahead and get started again. And we're going to turn it over to Cami Daniello.
Thank you, Penny. I'm hoping everybody can hear me okay. Get a few nods.
I can hear you fine. So,
All righty.
and I wear hearing aids.
Thank you, everybody. Go ahead and do the next slide, Esme, if you would. Workplace violence and abuse continues to be a very serious problem for Massachusetts nurses. 6 in 10 or 64% say workplace violence and abuse is a serious problem. This is very similar to a previous report, and I do have the citation at the bottom there for you all. 24% do not feel safe in their workplace, including 3 in 10 of those working in direct care at teaching and community hospitals. 7 in 10 or 68% of nurses have personally encountered at least one instance of workplace violence and abuse in the past 2 years. Every 36 minutes, a worker in a Massachusetts hospital is subject to an act of violence or a threat. And as you may know, The Pit, I took a lovely picture of Noah Wiley, which is dating myself because I used to watch ER when I was in nursing school, is a new show that has actually highlighted in a very clear way the issue of workplace violence for nurses. One of the main characters of the show was assaulted as part of her workplace as a nurse. And Noah Wiley and she have actually both been speaking out nationally on the issue of workplace violence. Next slide, please. In Massachusetts, I did want to give you a little bit of history about the issue of workplace violence and how long it has been an issue and being discussed. As early as 2002, when acting Governor Jane Swift defined workplace violence as intimidation or threats communicated by any means, physical assault and or battery, property damage, or other disruptive or aggressive behavior that causes a reasonable person to be in fear of their own safety or that of a colleague, or that causes disruption of workplace productivity. Violent behavior can include actions or communication in person, by letter or note, telephone, fax, or email. Incidents of workplace violence may be acted out individually or take place between employees and clients, customers, employees and acquaintances, partners, and employees and the general public. At this time, employers, specifically state agencies, were directed to establish a policy of zero tolerance, creating an environment that would encourage the discussion of workplace violence issues and where ER and emergency and reporting procedures are made known. So this was sort of the first point in time where that was discussed. And in 2009, Duval Patrick, again, an executive order. And we haven't seen too many of those lately, right? He established the state's initial framework for improving occupational health and safety for executive branch employees. It did not focus specifically on workplace violence, but it did create the infrastructure by which workplace violence is now dealt with and reported out in the state of Massachusetts. And again, required state agencies to align with OSHA standards. Go ahead and do the next slide, please. From again, a legislative point of view, something to keep in mind in that in 2013, Chapter 3 of the Acts of 2013 came out, which included a provision mandating workplace violence prevention regulations, specifically tasking the Executive Office of Health and Human Services in creating regulations to address workplace violence in human service settings, particularly for workers who provide direct client services. In February of 2015, EHHS issued regulations known as workplace, they established a zero tolerance policy for workplace violence. It required covered programs to implement a workplace violence prevention and crisis response plan with specific components, which included a clear definition of workplace violence, procedures for reporting incidents and threats, protocols for crisis response and follow-up, resources for victims and perpetrators, and prohibition on retaliation against employees for reporting incidents. These regulations, despite being in place, have not dealt specifically with the issue of workplace violence among healthcare workers and in hospitals, because they were really specifically directed at state agencies and or human service workers or social workers, not at healthcare workers. I'm going to do go ahead and hit it advance and just get the next thing to pop up as may. Again, dating myself. I don't know if y'all remember the very exciting Schoolhouse Rock, I'm Just a Bill, and hopefully that will not be stuck in your brain as a little earwig for the rest of the day. But one of the things to understand is how the legislative process works in Massachusetts. We have regulations such as the one I just discussed, and then you have legislation. And so in Massachusetts, we have a 2-year legislative session that begins in January of the odd years, which means that our current legislative session started this past January and will go through December of 2026. Every session, there are approximately 8,000 bills introduced into the Massachusetts state legislature. It takes an average of 4 sessions or 8 years to get a bill passed in the Commonwealth, which is very similar to that of the federal level. Again, if you really want the in-depth review, you go ahead and click the YouTube video or write that down and watch that later, but I did not want to torture everybody. Go ahead and click the next slide. So I wanted to give you a history of looking at an act required healthcare employers to develop and implement programs to prevent workplace violence. As you can see, it's been introduced since 2009 repeatedly and debated in multiple ways. Go ahead and click the next slide. And then ahead, see if we can, probably the most recent one that the legislation that has been ongoing and we've considered to look at was sponsored by the Mass Nurses Association and was also known as Elisa's Law. The specific provisions of this bill required hospitals to perform an annual safety risk assessment and implement violence prevention programs based on their findings. It guaranteed paid time off for workers assaulted on the job to address legal issues and required a semi-annual report on assaults against healthcare employees to district attorneys. The bill was specifically named for Elise Wilson, an emergency department nurse who was brutally stabbed by a patient at Harrington Hospital in Southbridge. The attack left her with life-threatening injuries and galvanized her colleagues in the M&A to push for a stronger workforce safety protections. While the Massachusetts Legislature's Joint Committee on Public Safety and Homeland Security approved a version of Elisa's Law in 2017, the bill did not become a law. The Mass Hospital and Health and Hospital Association opposed the bill, arguing that existing regulations and processes were sufficient and that the new law could create problematic duplication. Go ahead and do the next slide. I'm going to click along with it so I can read my notes. In 2019, again, there was House 1416, House 1976, Senate 1093. Again, going to the Joint Committee where they sponsored a compromise bill, House 4689, and which then ended up dying in committee. It was not passed. Go ahead and click on the next slide. However, what did pass in that legislative session was an act strengthening the penalty for assault or assault and battery on an emergency medical technician, ambulance operator, ambulance attendant, or healthcare provider. The statute divides healthcare provider to include any doctor of medicine, osteopathy, dental science, or a registered nurse, registered pharmacist, social worker, doctor of chiropractic or psychologist, or resident fellow medical officer licensed under, and they give the chapter, and it's employee of a hospital, clinic, or nursing home, its agents and employees. However, this is a very difficult legislation to prosecute. The Commonwealth has to prove the following. Number one, that the defendant intentionally engaged in actions that cause bodily harm or were intended to cause fear of harm, that the victim was an EMT, ambulance operator, or healthcare provider, and that the victim was treating or transporting a person in the line of their duty at the time of the incident. It specifically addresses the safety of the healthcare provider in the line of duty. It would not include, for example, a healthcare provider who was not treating a patient at the time. In self-defense, is considered a defense if the individual was not consenting to treatment and the force used was necessary and reasonable for them to be able to defend themselves about non-consent for treatment. The official statistics on the number of individuals actually prosecuted for assaulting a healthcare provider in Massachusetts are not publicly available. In Suffolk County, which is the greater Boston area, the district attorney's office says that about 50 people per year are charged with assaulting healthcare workers, with 32 charged in 2020. One of the things I think to keep in mind is that there are a number of assaults that go unreported and or are not prosecuted. The underreporting of assaults is due to for a number of different reasons, but one of the biggest one has been that the victim has to go to court and present themselves as the prosecuting individual in that case. They must file and appear before a clerk magistrate to get the case moving. And this is very challenging, especially if you're not able to take time off or have support to confront your assaulter. Go ahead. Thank you. Click the next slide. To where I was. Thank you. And go ahead and click the next slide. So for a couple sessions, what happened was the Joint Committee promulgated a compromise piece of legislation that took into account both perspectives from the M&A and the Mass Hospital Association. We did actually do ANA Massachusetts did do a comparison of the bills side by side to really look at the differences between them. And they were not significant. I think the biggest one was that one bill held the employer responsible, the other bill held the perpetrator liable. Paid versus unpaid leave to seek victim services, legal services. Do you tell the victim or do you just tell staff up front? So these were not what we would consider significant changes or differences between the bills, but we were really not seeing a whole lot of movement or ability on either side of the sponsors of each bill to move forward with making compromises. Go ahead and click the next slide. And again, in last year's legislative session, the 194th, again, we had both bills were reported favorably and referred to the Committee on Healthcare Financing, where it died in committee. And people will ask, well, why are these bills not passing? Why aren't we able to get this to move forward in the Commonwealth? Go ahead and click the next slide. And really, it's about political pressure, competing priorities, and a lack of consensus. There were groups such as the ACLU and prosecutors who actually opposed the bills as well, saying that the bills that were being proposed were very difficult to prosecute. I know ANA Mass did a lot of work around trying to elevate and include language related to psychological assault in both of those proposed bills. Unfortunately, that prosecutors have told us that is a very difficult piece to prove and to prosecute. So we are no longer advocating for that from an ANA Mass point of view. We're just advocating to move forward with the violence against healthcare workers legislation. There's a lot of competing priorities. With 8,000 bills filed every legislative session in Massachusetts, not every bill gets heard and not every bill gets to move forward. And because there's a lack of consensus, lawmakers can't reach a compromise on certain details, such as who is being held responsible, the level of leave, the enforcement penalties. There's definitely some obstacles in terms of reporting. There's a lack of awareness of reporting systems. Some healthcare providers are not aware of the procedures or systems available for reporting incidents. There's no universal agreement on what constitutes violence. My definition of violence and OSHA's definition of violence might be different. There's been underreporting of less severe incidents. For example, patients who have other underlying complications such as Alzheimer's, incidents of violence may not be reported as incidents of violence. There's been fear of retaliation from supervisors, and the perception that it's okay. This is something nurses deal with every day. It's part of the job. which is a perception, it's a normalization that should not be occurring, but unfortunately has. To address these barriers, ANA and ANA Mass are recommending that healthcare organizations do adopt a zero tolerance policy to foster a culture where all forms of workplace violence are unacceptable, to create a culture that supports reporting, developing an environment where employees feel safe and encouraged to report violence without fear of retribution, establish clear reporting mechanisms where you implement and maintain clear, accessible systems for reporting violence, providing education and training for staff on definitions of violence, reporting procedures, and the importance of a culture of safety. Also, the investigation of all reported incidents by a multidisciplinary committee to achieve positive outcomes, very similar to how the previous speaker was discussing and what they did at Parkland. Go ahead and click on the next slide, please. In April of 2025, House 2655, Senate 1718 was introduced, and there was a hearing, and it's the Workplace Violence Act, which is an act requiring healthcare employers to develop and implement programs to prevent workplace violence. Both bills were reported favorably and are now sitting in the House and Senate Ways and Means Committee. Go ahead and click the next slide. What is most critical is to look at this picture. And for those of you who are not familiar with Massachusetts, what you will see is on the left, Julie Pinkham, who is executive director for the Mass Nurses Association. I forget the name of the lady in the middle. She's from 1199 SEIU. And on the right is Steve Walsh, who is the CEO of the Mass Health and Hospital Association. It was extraordinarily unusual to see these three players at the same table testifying in support of the same bill in the Commonwealth. So I do actually would say that we have very high hopes at this point that this bill will move forward. It does have, go ahead and click the next slide, widespread legislative support with 68 total sponsors to date. And that was as of like a couple of weeks ago. Whether or not that's increased, I don't know. I can't keep track of all the sponsors of the bills. Lead sponsors are Representative John Lawn from Watertown, Senator Joan Lovely from Salem. I think the specific pieces that they've been able to come to compromise and agreement on is that all Massachusetts hospitals must develop a facility-specific risk assessment and use that to implement their comprehensive program to reduce the risk of violence. It engages the workforce, the nurses, in developing the assessment program, includes worker training and a formal written violence prevention plan. It establishes strong enforcement through DPH licensing, regular reporting, and job protections for affected workers that include additional paid leave for assaulted workers. And that's really important. The other piece I do want to bring up, and let me just pull it up on my other screen, is to really talk about, and I sent to Asma actually a little piece to send out to you with regards to the current status of the national legislation regarding workplace violence. In June of this year, over 500 nurses in Washington, D.C. did participate in what is called ANA Hill Day, and they did lobby for the Workplace Violence Prevention for Healthcare and Social Service Workers Act, House Resolution 2531, Senate 1232, which requires the Occupational Safety and Health Administration, OSHA, to issue standards regarding healthcare and social service employers, and workplace violence. It ensures that to ensure that nurses and other direct care employees are part of the development and execution of workplace violence prevention plans, with the ability to and flexibility to tailor the plan to specific units and patient populations, as well as specific environmental and population hazards. It allows nurses to do the one thing they do best, speaking up for safety. It also includes anti-retaliation protections that allow nurses to report workplace violence without fear of reprisal. One of the issues that has been a challenge is that the OSHA has not released a standard for workplace violence prevention in healthcare. So again, this is where you just have to look at the difference between the legislative process and the regulatory process. If OSHA would release their standard, and if CMS, which is the Center for Medicaid Services, would release enforcement guidance that say things like CMS believes that healthcare workers have a right to provide care in a safe setting, and require Medicare certified hospitals to demonstrate that they have workplace violence plans in place, then the regulatory piece means would be working towards moving away from workplace violence. Currently, we're working on a legislative process because the regulatory process is not moving along at a speed and in a manner at which we're actually meeting the needs of our nurses. One of the pieces I will say is that it's challenging sometimes to go to the State House and lobby directly. I know ANA just had a very successful lobby day last week where we had 150 nurses on the State House lobbying and meeting with over 100 different legislators. So I strongly encourage individuals to join their professional associations, ANA Mass, AACN, critical care nurses, whatever flavor is your professional association. We encourage you to join them and help support the work that they do. The other piece is to actually contact your legislators. Where do I vote MA.org is a real website. You can log on, you can put in your zip code, and they will tell you who your legislators are and enable you to contact them. I encourage you to become knowledgeable about your facility's violence prevention plans, educate staff on how to recognize potential violence, employ de-escalation techniques, and seek assistance, creating an environment to reduce the risks. Provide your resources and support programs for employees to help them cope with violent behaviors, and make sure that there are sufficient security systems, including alarms and personnel in place. At the end of the day, nurses vote, and meeting with your legislators and informing them, this bill is important to me, I want it to pass, is the most critical step that you can take in order to get workplace violence legislation passed to decrease the risks to ourselves and our fellow nurses. Thank you. And I stuck to under 20 minutes.
That was that was extremely well done.
Talk very fast, so sorry.
It was very nice. All of our presentations were amazing. Is Emily in on the screen now? Emily Rumble? Hmm.
She's here, but we can't hear her.
I'm there. I am.
Oh, there you are. Okay, good.
Yeah,
Emily is a DNP student at Regis, and I am going to give her 5 to 10 minutes to show you how, in fact, someone at the individual level can make a difference in a, other than what Cami was saying, which is so important, being active, with your state, etc. And clearly, our speakers have all done that. So, Emily, go ahead. Emily, are you sharing your screen? Let me see if I can get her and let her know.
It looks like she's trying to, but her screen's frozen.
Yeah, is that what it is?
Yeah, because her video's frozen too.
Oh dear. All right. Well, oh boy.
She may be trying to log back in. Do you want
Yeah,
to give it a minute?
yeah. There she is. All right.
figures, right? Right.
Yep.
Right when I'm about to go
So are
on.
you sharing your screen?
Yes, there we go.
Okay, because
Can
oh,
you
there you are. Okay.
can you see it? Are we good to go?
Yep, you're good to go.
So I don't know when I cut out, but just I'm Emily Rumble. I teach in the pre-licensure BSM program, and I'm a doctoral candidate here at Regis, and I work clinically as a neuroscience nurse at Mass General. I would like to acknowledge the irony isn't lost on me that my last name is Rumble and my doctoral project is on violence. but I want to thank Penny and the rest of the program for allowing me to spread awareness on my project, the effect of workplace violence education on the pre-licensure student nurses' self-confidence. So as we've all heard the staggering statistics tonight, and I mean, they keep getting jaw-dropping as I hear more, nursing education can't ignore the realities of healthcare. So many topics in academia are being taught because that's the way it's always been, but it's time to change our curriculum to better reflect the real world topics that are affecting the nursing profession and better prepare our student nurses for what they're going to face on a day-to-day basis. So with self-confidence, my is a belief that one's capable of successfully meeting the demands of a task. And my complex education is starting with the basics that typically involve multiple interventions. So this is online asynchronous learning, in-person didactic, and a simulation experience. So student nurses are more vulnerable compared to professional nurses due to their limited knowledge, limited experience, and the feeling of powerlessness. As Deb and Cami all mentioned, since the events aren't always reported, their students experience a range from 42 to anywhere to 98% of events. We have to acknowledge this to avoid increased attrition rate of student nurses and perpetuate the nursing shortage crisis. So there's a gap in the knowledge on how to prepare student nurses for workplace violence events and identifying which training is appropriate. Student nurses are struggling to manage events in their clinical training. They need to be taught resiliency skills to cope and better prepare for their new graduate nurse roles. And according to Al-Shawish and al., providing workplace violence training while students, that
Emily, you froze again. Oh dear.
I'm sorry, I don't know.
Yeah, you froze again, but can you, do you think, I don't know how many slides you have, but I'm getting nervous. So I'm wondering if you can say, sort of define what you're doing
Sure.
with this.
Yeah, so basically, what I'm doing is a quantitative evidence-based project with a pre and post-test survey. And the students, IRB has approved my project. I'm in the first step. So people have started the pretest and I'm in the recruitment process. And on October, I'll be implementing my simulation with a simulated patient and an aggressive scenario. And my plan is to teach students how to, with cognitive rehearsal training and just the proper body positioning to protect themselves, because they're experiencing the same as nurses in their clinical setting. But we're not talking about student nurses, we're only talking about nurses. But that's going to affect our nursing shortage and our new grad attrition rates. So we need to hit them early with the education instead of waiting for when they're at the new grad position. So like I said, the simulation is on Halloween and I'll be doing a post-test survey 4 weeks later. And I'll be comparing the means to hopefully prove that it increases their self-confidence and that we should be putting this in the curriculum rather than just waiting until they're naive and stepping onto the floor. We should be preparing them better. So as an educator, my passion is to make sure the students are prepared and start focusing on what they're really going to be facing and not just, some things in the nursing books that they'll never see. So thank you again. I'm sorry for all the tech
Oh no,
difficulties.
that was
What a
amazing.
bummer.
That's really good though. It's really important. Yes, I love this person who keeps putting up the clapping hands. It's awesome. Um, so all right then, Betty, do I want to turn it over to you?
Yeah, absolutely. Well, I want to first thank all of our panelists for such thoughtful, honest, and at time really sobering insights. We've heard today that workplace violence in healthcare is not a peripheral issue. It's structural, systemic challenge that touches everything from staff well-being to patient safety to the integrity of our care environments. And Emily, you know, really something that's probably not been on our radar are student nurses. We've explored how this violence manifests from verbal threats to physical assault and how it disproportionately impacts settings like emergency departments, mental health units, home care. But we've also heard about hope, about prevention programs that work, leadership that listens, frontline, frontline staff speaking out, and legislation that could provide meaningful protection. And I think, Karen, your presentation for me was incredible because a lot of what you're already doing, um, these are concepts that are being discussed and right here in Massachusetts in many of our bargaining units, and you're providing a benchmark, right? It's already there. So I commend you, the entire team, everyone, and thank you so much for bringing that to all of us today. Um, Certainly, one thing is clear. Change will require more than just policy or training. It's going to take cultural shift in how we define safety, support our workforce, and hold organizations and systems accountable. With that, I would love to open the floor to questions from the audience. And whether you're here as a healthcare worker, a student, your voice is part of this conversation. So I can open it with a few questions of my own, unless there are some already posted or that you want to. I know we're kind of cutting it close on time, so I want to make sure everyone's questions are asked. If not, I can pose some to the panelists.
I just have a comment, and it goes to Emily's idea. I will say back in 2021, as part of a workplace violence grant from the Texas Workforce Studies, we did do a presentation to some nursing students. And that was one of the areas where we were able to capture money. And I agree with you totally that this needs to be incorporated into the nursing curriculums. I applaud your work in that space. I don't know how to do that. I'm trying to do that in my own area. I also feel that the education of how we look at education, mainly training in this space of how people actually respond because it's on muscle memory. We've got to get away from this being non-productive time. This is how we've got to move into a space that this is totally productive on how they respond at the bedside. And so, this non-productive, how we actually time them out of the unit, we really have to, have a reframing of how we look at this.
Thank you, Karen. Penny, are there any questions or should I pose one to the panelists?
I don't see any, and I know Asme is monitoring them, so she'll let us know, I'm sure.
Okay.
Nothing's come through in the chat.
Okay.
So one of the questions that I have is, and Karen, you may be able to speak to this, or JD, right? But I'm interested in how you sustain momentum over time when you're implementing a lot, or when you did implement. I think one of the things that we're experiencing within the M&A and the varying bargaining units is kind of an initiative fatigue, in that there's so many different initiatives, and perhaps our healthcare workers are not seeing rapid enough or large enough impact.
Well, I think it's twofold. You have to find the people who have the passion around it. And when I started this in 2018, even before JD came on board, I've got a larger job, but I found a passion for it. And I worked with the head of emergency room physician and the head of behavioral health to really develop a chartered committee that then had the different prongs to it. It wasn't just clinical, but I also had done some shadowing in the ED, and while I was there in the ED, I was really stunned at what I saw, and utilized a de-identified video of an individual that was probably 6'7", 300+ pounds, totally naked, just taking out everybody in his path, high on something in the ED, and that's how I opened up the start of our committee. I said, "This is real. This is what we're doing." And in order to get more positions, I actually took verbatim, words that had characters in them that were cuss words, swear words, things that you should never hear in our healthcare organizations, and put them in front of the executives. I said, this is what they are subject to. And you've got to get the message across. I mean, I spoke at the State Nurses Association in Alabama earlier this year, and they're struggling. And I even took their law and I made a gap analysis just like I did ours. And we were very deficient in our gap way back when, but we still continued to work really hard. And their struggle was the state association didn't believe it was happening. I said, you've got to get these people in front of those state legislators to say, this is a real issue. So it's about people that have passion. I don't take no for an answer very well. It's timing. I mean, even for like the Sparks program, I found people that were passionate about peer support. We were under a corporate integrity agreement. We didn't have any bandwidth. And so we made it happen. So it's pulling what you can out of your back pocket and continuing to support one another, even when people don't feel like they have any more energy.
If anyone can do it, nurses can, right?
Yeah.
And the worst thing you could tell a nurse is you can't or you won't.
Right,
So,
exactly.
amazing. I did see a question pop up on the chat.
Where did you see it?
While Karen was speaking,
And Emily, I'd love to partner with you if I could, down the road. It would be
Oh my
it would be
gosh,
awesome.
that would be so great. Yeah, thank you so much for your support with it. I would love to keep in touch.
Mhm.
so there is a question
I
here
see
that
the
says,
question.
yep, what are our next steps? We have all the tools at my job and I don't know if it's deficient, I think,
Or
cultural or definite cultural ship
Mhm.
and and the extra peer support for these situations.
our next steps. Wow. So it's not really a question, but
Oh, okay.
it's really saying, I mean, it's amazing how, Karen, how you and your whole institution attacked every aspect
Mm.
in terms of dealing with the consequences. Deborah, I'm wondering how you experienced the program that Karen was describing.
Yeah, and to
Yeah.
me, it was, first of all, that's a huge hospital. It's like, whoa.
Yeah.
And I think it's amazing. I think that a lot of other facilities that I've been in as a nurse or as an educator visiting from Regis have a lot to learn by what they've been able to accomplish.
Right. That's absolutely amazing. Um, there is one thing, if I can, I'm going to let Betty tie this up, but one thing I'm going to do is I have a poll that I'd like to just put up, and I'd like participants to spend, 1 minute just answering 3 questions, so that I can also close out with that, even while you're maybe doing your evaluation. So, all right. So Betty, anything else you want to say?
I really just want to thank everyone, panelists and attendees alike. I think attending sessions like these are really, really important, but it's not losing that momentum. It's what are you going to take from these sessions and bring forth and share with colleagues and in your facilities and take action. So I invite all of you to do that, even if it's just sharing one component of what you learned today with a fellow healthcare provider, and just don't sit idle.
Thank you, Betty, and thank the panelists so much. JD had to go because he's actually having dinner with some state legislators today, or right for dinner tonight. So he said thank you very much, and he was honored to have been able to present as well. So I think Esme can post the evaluation link up there, and I'll go ahead and see if I can pull my little 3 questions up. All right, and our panelists are free to go. And thank you very much.
Thank you.
Thanks, everyone.
Thank you.
Good night.